Hello everyone. This chapter is titled Chapter 16, Alterations in Blood Pressure. In this particular chapter, we will be focusing on everything that has to do with blood pressure, starting off with the anatomy and physiology of how the body regulates blood pressure, and then getting into the pathogenesis of the topic hypertension in detail. Arterial blood pressure is the pressure differences between left and right sides of the heart that produces the gradient along systemic movement of blood. I think we should all have an idea by now that when we're measuring blood pressure, we're measuring pressure of blood in an artery and not a vein. The reason why is because arterial blood actually takes blood to the entire body systemically. So this is what we want to measure, the systemic movement of blood. Arterial blood pressure is produced by the force of the left ventricular contraction overcoming the resistance of the aorta to open the aortic valve. So again, that left side of the heart where we now have a large amount of blood that forces through the aortic valve, that valve opens up, pushes a very high velocity of blood through circulation systemically through the body. And this is the pressure that we want to measure. So there are a few determinants when we're discussing systemic blood pressure. One factor is something called cardiac output. Cardiac output and the resistance to the ejection of blood from the heart. I will tell you this now, it is extremely important to make sure you know this equation. CO, which stands for cardiac output, equals SV, stroke volume times HR, the heart rate. This concept is extremely important to know. So I want us to know this equation, not only just for, purposes of doing a math problem. We won't have a math problem or an equation on a test. However, it is important to know these concepts. So stroke volume, if you remember from physiology, is the volume of blood that leaves the heart, okay, per contraction, heart rate or heartbeat. So when we have the combination of the two, this is what we call the cardiac output. It's a measurement of the amount of blood that's leaving the heart per heartbeat or heart rate, or as the heart rate is correlated with it, excuse me. So again, very important concept to know because there are a number of cardiac conditions that we're going to cover in chapters 18, 19, 20 that all correlate to patients having alterations in cardiac output. And as nurses, when a patient's cardiac output is low in many cardiac cases, the goal here is to actually reverse that into increased cardiac output. So that's making sure that the patient's heart rate elevates or the stroke volume increases, whatever the case may be, but to make sure that cardiac output is elevated. Now, within diastolic volume is the preload, and systemic vascular resistance is what we call the afterload. So another way to kind of, let's say, visualize this or to understand it, going back to physiology, the preload is the volume of blood that's in the heart before it leaves the heart or before the contraction happens to push it out. Whereas afterload is going to be the amount of blood that now leaves the heart that is out in circulation. Okay. So end diastolic volume is the preload. Systemic vascular resistance is the afterload, which means that the amount of blood that leaves the heart is now in systemic circulation, so it's in the systemic vascular area. And so this resistance is determined by the radius of the arteries and the degree of vessel compliance. So when we're measuring a blood pressure, again, it all goes back to how we correlate that preload and afterload and what's happening here. So to get started, a systolic blood pressure is measured by the peak pressure during cardiac systole. So this is something that you guys went over, I'm quite sure, in physiology. This is going to be the highest pressure point, okay, or another way to explain this is systole is when the heart is contracting, whereas diastole is during relaxation. So diastolic pressure will be the lowest pressure point. So just to kind of tie this in, and I'm going to add in this the SV. The SV here stands for stroke volume, which is the volume of blood that leaves the heart per contraction, as we went over in the previous slide. And that's the primary factor for systolic pressure. SVR is abbreviated for systemic vascular resistance, which is the afterload, which we just went over in the previous slide. And this is the major determinant for diastolic pressure. So let me try to paint a picture for you. So let's say you have a person that is now having a contraction of the heart, and through that heart contraction, the volume of blood that's now in the heart is going to contract and be forced out into circulation. So when that volume of blood that's contracted and forces out into circulation, this is what we call the systolic blood pressure, because it's the highest pressure point. It's at the highest velocity that it can be, especially if we're talking about left-sided circulation, and it pushes that nice force of blood out into circulation. So this is what we call systolic pressure. Now, as that volume of blood is moving through the vessels, it's actually going to start to slow down. And the reason why it slows down is because we do have something called systemic vascular resistance, which is the resistance of blood against the wall of the vessel. Okay, and as that is happening, this is now slowing down the velocity of blood. And as we have that volume of blood slowing down, this is what we call the systolic blood pressure. Okay, so hopefully that makes sense. Now, we do also have ways of measuring blood pressure. So we do have something called a direct measurement of blood pressure, and then also an indirect. So I'll start with the direct first. This requires a catheter that is placed in the radial artery. This is definitely the most accurate method of measuring blood pressure, but I just want to make you aware it is not the most common way that we measure blood pressure. This type of blood pressure measurement is invasive, as we would imagine, and it is only used in surgical situations, and also when patients could be in critical care or ICU and things like that, in certain situations, but not every case. Okay, so this is not the common way of measuring a blood pressure, but it is the most accurate method. The indirect measurement of blood pressure is the more common way that we measure blood pressure. So this is using a stethoscope, the sphygmometer, and what happens is, quite sure we've all taken a blood pressure at some point. The stethoscope goes on the brachial artery, whereas the sphygmometer gets wrapped around, or the blood pressure cuff gets wrapped around the patient's arm. Okay, and so what will happen here is that we will now start to increase or put pressure, okay, on that particular arm, so we can put pressure on the brachial artery. The more pressure we put on that brachial artery is going to cause the blood to pool in that particular vessel. And we're looking for just what we said earlier, how that measurement of blood, we're the highest velocity and then the lowest velocity. So in order for us to hear that, we do hear or auscultate for what is called cortical sounds. Cortical sounds are basically the sound of blood that's hitting up against the wall of the vessel. And if you listen to it as you're taking a blood pressure, it sounds like a heartbeat, but it's basically the sound of the blood hitting up against that wall. So when we hear the first sound that sounds like a heartbeat, it's always good to take a visual measurement, or a visual, I should say, note as to what number is on the dial of your blood pressure cuff, because that's going to be your systolic reading. And then it's going to continue to beat, and as it continues, it's going to get to a point where the beat will stop. When the beat stops, that's going to be your second reading, which is your diastolic reading. And so this is how we measure a blood pressure. As it also states in this slide, it does require careful technique to ensure accuracy. There are many, many things that are very important when taking a blood pressure, making sure the patient's relaxed, feet planted on the ground if they're sitting, even if they're supine in the bed, they should be as relaxed as possible. The nurse or what the clinician should hold the arm, so the arm is kind of cradled and the patient not holding it out for them. There's so many things. So we will go over more of the techniques in class, because we usually do an in-class activity where we are doing a hypertensive evaluation on each other. And so we'll continue more of that during class time. Okay. Okay, now to continue on with blood pressure regulation, there are a number of things that can affect blood pressure. This can be normally or in a situation where we have a pathogenesis or some sort of disease process causing this to occur. However, normal things that do regulate blood pressure can be affected by neural, humoral, and renal factors. We know, number one, that the nervous system and the endocrine system can actually work together to regulate a lot of different things in the body. I think we saw this in chapter 2, how the nervous system actually can fluctuate blood pressure. One thing you also went over, and we'll cover this again in the next few slides, is that the renal system is very, very important when we talk about blood pressure regulation. It's very difficult to talk about normal blood pressure regulation without describing the renal system, because the renal system is basically the system that correlates with how blood circulates, how it flows, the pressure, the things that are released to allow pressure to be regulated. So blood pressure can fluctuate over a 24-hour period due to physiological changes associated with the circadian rhythm. And that's very important to know as well, because if you have, let's say, a patient that's taking their blood pressure at home to monitor for purposes of managing their hypertension, it is important to make sure that they're taking their blood pressure at the same time each day, whether they're taking it prior to medication or after medication. Very important that they stick to that particular pattern, because when we first wake up in the morning, our blood pressure is a little lower, and that's normal. However, as we move about the day, the blood pressure should regulate a little bit, and as we start to wind down at night, it may drop a little bit as well. So it does fluctuate throughout the day, 24 hours of the day, especially while we're sleeping. And so again, very important to know those things, especially when you're monitoring blood pressure. Okay, so the next slide, or I should say this particular slide, now starts going into deeper physiological mechanisms that correlate with how we regulate blood pressure in the body. So to get started, I want to make you aware that the body will regulate blood pressure in a sense of where we have short-term as well as long-term regulation. So we're going to start off with short-term. If you want to, let's say, short-term can be maybe associated with a quicker reaction, a faster reaction, in a sense of short-term. So changes in BP, changes in blood pressure, are mediated through activation of the sympathetic nervous system. It results in the release of neurotransmitters, epinephrine, norepinephrine, and also our vasomotor center will indirectly activate our baroreceptors. And these baroreceptors will activate alpha receptors and smooth muscle arterioles, and it will also activate beta receptors of the heart. So let me give you an example of how this works, and then I'm just going to add in a few more things here. So let's use an example of, let's say you eat a large breakfast. Okay, I love breakfast. So I usually eat a very large breakfast. Now, let's say someone eats a very large breakfast and they are now full, very relaxed, and let's say that they're just kind of, passed out on the couch and, just taking a nap. Okay. So what's going to happen here at this point when you are finished eating and your body's just kind of in this sort of mellow state, your blood pressure will probably drop a little bit, okay, because of we're in that state. Now, what will happen is if your blood pressure tends to drop a little too low, the body will recognize that and actually start to kick in mechanisms to bring it up, okay? Now, you're probably wondering, bring it up, not bring it up in a sense where we're bringing it up too high, but we want to bring it up back to normal. Keep in mind, the human body has a lot of regulatory centers inside of it, in a sense where anytime we sense that things are out of homeostasis, as we learned in chapter 1, that we have mechanisms that fall under allostasis, which will bring it back to normal. So we do have these regulatory centers. So the body will sense that the blood pressure is too low. When it senses that the blood pressure is too low, it will actually start to kick in mechanisms to bring it up to normal. Why do we want to be concerned about that? Well, we need to make sure that we have normal blood pressure flow for normal flow of blood, so we can get blood to all of our cells and tissues and organs, and so everything that can function the way it should. Okay, so getting back to this in the PowerPoint, and I'm going to jump down to where it says, and I'm going to try to highlight this area for you, where it says it activates alpha receptors and then it activates beta receptors. Oops, I'm sorry, not that great at the drawing here. Or actually, probably my best thing to do is to highlight. Okay, that's better. Okay, so activate alpha receptors and activate beta receptors. Now, the reason why I'm putting a little more emphasis on this particular area is because these receptors that are located on the arterioles in the heart will directly affect what's going to happen to blood pressure. So in the example that I gave you of the blood pressure dropping too low, what will happen is, let's say it will activate alpha receptors in smooth muscle or arterioles. Okay, and what it's going to do to the arterioles, if you want to note this, to put a note here, I don't have the capability to type here, but if you want to note here, it will cause the arterioles to actually constrict. Okay, so it will cause the arterioles to constrict. The beta receptors of the heart will cause the heart to relax. Okay, so that's what we want to add to that, to relax. Not relax, I'm sorry, to contract, So we have a constricted vessel, arterioles, and then a contracted heart. Now, so everything's constricted and contracted. Now, in order for blood pressure to elevate, we need to have pressure. So the constriction of the arterioles is going to constrict that vessel, so it increases pressure in the vessel. It contracts the heart, so the heart can push out more blood. So now the combination of the two is going to cause more pressure in the vessel and now increase blood pressure, okay, in the system. So that's the purpose of that. Now, as a side note, you're probably wondering, why arterioles? Okay, we have other vessels, we have arteries, we have veins, we have venules, okay, or capillaries. Why arterioles? Well, to bring you back to anatomy and physiology, if you remember, we have arteries, arterioles, capillaries, venules, veins, and in that order. And when we have blood in an artery, It has a very, very high velocity, as we know. The next vessel below that are arterioles. And what arterioles do, they actually constrict, dilate, back and forth to actually slow down the velocity of blood. They are a very, very key factor when we're discussing blood flow and blood flow and blood pressure regulation. And the reason why is because we need to make sure that velocity of blood slows down before it gets to the capillaries, because the capillaries, we know, are very thin. We don't want that high velocity of blood just kind of rush into it and bursting those capillaries open. So we want to make sure that the velocity of blood is controlled. And the vessel that controls this is arterioles. Please make sure you know that arterioles are very, very important when it comes to blood pressure regulation as far as the vessels. Okay, they are the most important vessel here. So that's that. Now, I just want to also show you how, and I think I can type this in this way. Maybe not. Okay, I'm trying a new feature here, and let's see, it may not be working. Okay, that's all right. So I just want to explain that we do have a category of hypertensive medications, and we're going to go into more detail with this. I think I have a separate slide that goes into all the list of them. But we do have two hypertensive medications that actually counteract this pathway right here. So you see where I highlighted alpha receptors and beta receptors? Well, we do have medications that are called alpha blockers and beta blockers. So an alpha blocker is going to do exactly what it says in the title. It's going to block the alpha receptor. And so when we block the alpha receptor, instead of the arterioles constricting, they're actually going to dilate. Okay, so they're going to dilate. So an alpha blocker will cause the arterioles to dilate. A beta blocker will block the beta receptor, and so what it will do, it will actually cause the heart, instead of contracting, it will cause the heart to relax. So the definition of a beta blocker, the beta blocker will actually relax the heart. So in these two medications, you have the arterioles dilated, the heart relaxed. And in both cases, when you open those vessels and have the heart relaxed, in that sense, it now calms down the pressure and decreases blood pressure. Okay, so hopefully that makes sense to you. Now, the next area here, we have long-term regulation of blood pressure. Now, this should look familiar to you from physiology. I think we all know that this pathway helps the body in a sense of long-term regulatory mechanisms to make sure that blood pressure is at its normal pressure point. So we have angiotensinogen converting to angiotensin 1 by the way of renin. Okay, we know renin comes from the kidneys. Once we get to angiotensin 1, it converts to angiotensin 2 by the way of angiotensin converting enzyme. Once we get to angiotensin 2, it will cause vasoconstriction on one side, so which means that the vessels are going to tighten up real tight. On the other end, it causes aldosterone to be released, and once aldosterone is released, it will cause sodium and water to be retained in the kidneys. And if you retain sodium and water in the kidneys, this actually increases body volume, which in turn increases blood volume. And the more blood volume that we have in a constricted vessel on the other side there, the combination of the two will increase blood pressure. Okay, so that is the physiological mechanism of how blood pressure is regulated in the sense where it elevates when the body is low. Now, just as a side note, you hearing me discuss, okay, when the blood pressure is low, this is what the body will do to bring it up. What happens when the blood pressure is high and the body needs to bring it down? Well, the body does not have really good regulatory mechanisms to bring blood pressure down when it's really high, which is one of the reasons why hypertension is a condition that will be here until the end of time. It's our physiological makeup cannot handle very high blood pressure and bring it back down to normal. When blood pressure is really low, it can kind of balance itself out somewhat, even though hypotension is an issue as well, which we'll talk about at the end of the chapter. But hypertension is definitely a major issue. And the other piece of this is that, especially primary hypertension, we do not have a known etiology for it. There's no known cause, which means that these patients, and for those of you who are already working in the field and know about hypertensive medications, know that sometimes patients can have their hypertensive medications change frequently, okay, or from time to time, because one hypertensive medication may work and then that's not working, so let's try something else. And the reason why it really comes from this pathway, because we have no idea what part of the pathway here is the issue. We don't know if it's too much angiotensin converting enzyme. We don't know if it's too much aldosterone. We don't know if it's too much sodium water retention. We have no idea what part of the pathway is the issue. There's no way to actually test in that much detail of it. So the medications are pretty much given, based off of clinical trials and that sort of thing. So saying that, getting into the medications, we have a list, or I should say a number of medications that can counteract this portion of the pathway here. So the first one we have is the angiotensin converting enzyme, and I'm going to highlight that one here. So also known as ACE. So we do have medications that are called ACE inhibitors. So an ACE inhibitor is going to do exactly what it says in the title. It inhibits the ACE. So it's going to stop or block the conversion of angiotensin 1 to 2. Okay. The next area here we have vasoconstriction. So there are medications that are called vasodilators, okay? And so we do have a number of different types of meds that fall under vasodilators. And so that's going to do the opposite of what is happening here, vasoconstriction. Then we have medications that are called aldosterone receptor blockers. So basically it blocks the release of aldosterone. And if you block the release of aldosterone, then the rest of this pathway will not continue. Okay. And then we have another type called diuretics. And so here when we have the sodium and water retention, where water is being retained, a diuretic is going to release that water. So it's going to do the opposite. So if you release that water, the patient's going to urinate. That should help decrease the body volume and therefore hopefully decrease the blood volume. Okay. Blood is body fluid, excuse me, which means that blood and water or other fluids in the body go hand in hand. So, and we'll see this in a little more detail later. So hopefully that makes sense. So here are a list, and I just put this slide here. I pulled it off the internet. And this just kind of goes over some medications. Some of these we went over already. Thiazides cause the kidneys to increase urine and reduces excess fluid. You know, kind of like a diuretic, or is a diuretic. Beta blockers, we already went over those, so we know they're going to react on the heart, cause it to slow it down. ACE inhibitors, okay, we know what they do. We also have angiotensin 2 antagonists, which that one I didn't go over. Alpha blockers, we know what they're going to do. Then we also added in here calcium channel blockers. Okay, so, and they're going to help relax the blood vessels. Now, these are just additional medications, and I just put these here just to show you what it looks like. We don't need to know the cost per day, but as far as focusing on the types of medications, if you do have test questions in the future, in my class with medications, it's more so just making sure you know the medication and know what the action is of that medication, and that is it. So I would go over the ones that I just went over in the short-term and long-term regulation, and also you can just take a glance at these here in this chart. But I just put this here because it was already packaged really nicely. But we do not need to remember or memorize the cost per day. That's not necessary. Okay. Okay, hypertension. This is the most common primary diagnosed condition in the U.S. Um, as I said before, hypertension is a condition that's it's not going anywhere. It's going to be here until the end of time. Um, just to make you aware, the most commonly primary diagnosed conditions in the U.S. are cardiovascular related, which means that most cardiovascular related conditions are modifiable. Okay, most of these things are modifiable due to diet and exercise. So it's very interesting that it is probably one of the primary diagnosed conditions, top killers, um, cardiovascular, cancer, things of that nature. And sometimes there are things that can be modified with the individual to kind of decrease this incidence. So, however, it increases the morbidity and mortality associated with heart disease, kidney disease, peripheral vascular disease, and stroke. Um, when a person has hypertension, we're not just concerned about the hypertension only, but we are concerned about the hypertension leading into what we call in-organ damage, which means that it can now damage other organ systems that are related. And as you can see here, it is responsible for annual worldwide death rate of 7 million. Okay, so that is a lot. We do have a classification that allows us to determine what stage a patient has with hypertension. The earlier that we can prevent this from happening, early prevention is the best. Okay, so there is a particular committee called the Joint National Committee on Prevention and Detection, Evaluation, and Treatment of Hypertension. The classification has changed with this committee, so basically they are moving the numbers around or changing the numbers to broaden the area to where we can catch patients a little earlier. Okay, so the prehypertension range is a little different now than what it was years ago. Okay, so let's take a look at this. Now, from my understanding, and this video is being recorded in 2020, just to make you aware. This chart comes from the textbook, or this is from the 5th edition, but I want to say this is the same chart in the 6th edition as well. So anyway, long story short, it is, to my understanding, that they are changing this classification, and they're going to change the numbers to broaden it so we can catch people a little more earlier with the prehypertensive stage, because if we can catch them there, then it won't progress as fast or quickly, leading into other issues. Okay, so anyway, we are going to use the table that is in our textbook, which is this one here, table 16-2. I believe I told everyone that I do not test you on numbers, okay, for our quizzes and exams. However, these are the only numbers that I will test you on, because the blood pressure classification numbers are important to know. I can incorporate this as a test question, and so we'll memorize this chart here. Okay, So just to go over really quickly, normal systolic should be below 120, diastolic below 80. Prehypertension is somewhere between 120 to 139 for systolic. For diastolic, it's somewhere between 80 to 89. Stage 1 is going to be between 140 to 159 for systolic, whereas diastolic 90 to 99. And stage 2 would be anything that's over 160 for systolic or over 100 for diastolic. And these are the numbers here, classification numbers, okay? And so just to make you aware, even though this is from an older book, or as you can see, they changed this in 2003, and not to date myself. um, Hold on a second. Okay, so not to date myself, but when I was in school, um, these numbers, the prehypertensive range was actually normal. Okay, so now that normal is now prehypertensive. Okay, so they have changed this over the years, and again, they probably will be changing it later on. Okay, so that's that. Now primary hypertension is what we consider idiopathic, which means that we do not have a known cause for this particular disease. Um, we have many risk factors for sure, but we don't know exactly. It is the most common form of hypertension. They do say it is rare prior to the age of 10. And even though 10 sounds like that's still a early number, but just keep in mind that unfortunately children are developing primary hypertension at higher rates now because of the diet and obesity and things of that nature. So when a person has primary hypertension, there are different subtypes. We have what is called an isolated systolic, where the systolic reading is higher um, than normal. We also have an isolated diastolic, where that number is higher than normal. But we can also have a combined systolic and diastolic hypertension as well. They do believe that when patients have a systolic blood pressure, that it's a much major risk factor for a subsequent cardiovascular disease. So primary hypertension, we do have a number of risk factors. Risk factors that are non-modifiable are family history, age. Um, for modifiable, we do have dietary factors for sure, sedentary lifestyle, obesity, and this metabolic syndrome, which kind of incorporates all of that, where the patient has obesity, um, maybe they're incorporated with this blood pressure issue. They could have also diabetes mellitus type 2 incorporated with this. So this metabolic syndrome also plays a part into hypertension. What we'll notice later on is that patients that are diabetic are definitely at risk for hypertension, and sometimes it can go hand in hand, especially if the diabetes is not controlled. But I don't want you to think that hypertension leads into diabetes, but diabetes can lead into hypertension. Okay, if that makes sense. Now, what we are concerned about, as we said earlier, is that these patients can have what is called in-organ damage. So when we say in-organ damage, this increases the myocardial workload, which results in heart failure. We can have renal issues or renal failure because of glomerular damage. It can affect microcirculation of the eyes, increase pressure of the vasculature in the cerebrum, and result into hemorrhaging. Okay, so this next slide gives us a breakdown of everything. Now, I know this diagram looks a little crazy, but I do want you to Number one, have an idea or know the organs that are affected. Okay, so that's extremely important to know. So those are the ones that are in burgundy there. So heart, arteries, kidneys, brain, eyes. It is very, very important to know at least the organs that are involved. Now, you guys can take a look at this flow chart, but I'm just going to try to sum this up for you. So when we have the heart, because a person is hypertensive, it's actually going to put a lot more work on the heart. So just imagine if you have so much pressure in the heart, well, the heart's going to try to work a little harder to kind of, push that blood somewhere else. So when there's an increased workload on the heart, it can actually increase oxygen demands from the heart. So it can work faster or harder, which can now lead a patient into a stable angina. This overworking of the heart can also overwork some of the ventricles and actually cause the ventricles to get enlarged. And anytime you have that, then blood can become stagnant, and this can lead into what we call congestive heart failure. Okay. When it comes to arteries, when blood is in an artery and it's pressurized in an artery, what's going to happen to this situation, and we discussed this, I believe, in chapter 15, it can now cause the arterial wall to stretch out and bulge and lead to what we call an aneurysm. Okay. Kidneys. Kidneys, number one, are very, very important in autoregulation of blood. So if the kidneys aren't, or I should say, if a person has hypertension, this is definitely going to directly affect the kidneys. It will cause failure of autoregulation, lead to ischemia, possibly hemorrhaging, and it can definitely lead these patients into end-stage renal failure. For the brain, if a person's hypertensive, what can happen is it can increase the vasculature that's going to the brain tissue. That can actually cause what we consider a hemorrhagic stroke, where there's a bleed that develops, and that can occur. In the eyes, we can also have this increased pressure to the eyes, to the vasculature, causing hemorrhaging, to blindness, even retinal detachment. Okay, so we get the idea as to what could possibly happen here. Okay. Now, for treatments for primary hypertension, one major thing that's extremely important to stress is lifestyle modifications. Most of the times when people think of hypertension or any disease process, they want to jump right to medications. Medications, yes, can be very helpful in some cases, but when you have cases of hypertension that when a patient is, let's say, in a pre-hypertensive stage, they may not need to start taking, tons of diuretics or ACE inhibitors or what have you. They may just need to actually change their lifestyle. So lifestyle modifications are the first and most important prevention and treatment strategy. Okay, even when a patient is on medication, they should also monitor their lifestyle changes. So drug therapy for hypertension addresses the heart rate, the stroke volume, and the systemic vascular resistance. So this table here, I'm not going to have you memorize each and every item here, but I just want you to take a look at this and digest it in a sense where we know the modifications that can be discussed with patients and have an idea as to the reduction that it can cause with systemic pressure. So, or systolic pressure, excuse me. So what happens here, the first one we have is weight reduction. Weight reduction is definitely one of the major things when we talk about hypertension. It can reduce, as you can see here, somewhere between 5 to 20 millimeters of mercury. That is a lot. That's a lot. That can bring someone from one stage to the next, or stage 1 to prehypertensive. The next one we have here is the DASH diet. The DASH diet is basically these patients now increasing their fruits and vegetables, staying away from saturated fats, and just having more of a healthier diet. That can also change the range of blood pressure as well. Decreased sodium intake. Sodium, we know, tends to play a major part as well in blood pressure regulation. As you can see, it only changes 2 to 8 millimeters of mercury, and you're probably thinking that, oh, it should be way more than that. But I want you to understand that sodium is also distributed on a cellular level. Okay, so sodium is used for many, many different types of things. So even though decreasing the sodium intake is a good idea, but it does also have other roles, okay, on a cellular level. The other piece to the sodium is that the more sodium, it's more associated with the water that can follow behind it and the fluids that can build up in the patient. So that also correlates with that. And then exercise, we want to exercise for sure. That helps. And then alcohol can also play a part in this as well. So for secondary hypertension, this is really easy to understand. These are basically patients that have a primary condition first that's already diagnosed. So let's say they're diagnosed with kidney disease or whatever the case may be. They have a primary diagnosis, and then now a hypertension results from that primary diagnosis. Okay. And so they know why the patient has hypertension, and it's because of the primary diagnosis that they have. So, and we have a list of those items here. The next category is something called hypertensive emergencies and urgencies. So, a hypertensive emergency is when a patient has a sudden increase of either systolic or diastolic or both, and it actually results in organ damage. So, let's say a patient blood pressure shoots up really high, and then they lead into retinal hemorrhaging, or they have a hemorrhagic stroke or heart failure. So, this is what we call hypertensive emergencies. Um, this definitely needs rapid control, reduction of blood pressure, and they also have to be monitored closely. They say these patients are typically in ICU because of that rapid end organ damage that has occurred. Hypertensive urgency, um, just like when we go to urgent care, it's urgent but not emergent. So in this sense, this is when blood pressure elevates without the evidence of end organ damage. So the blood pressure is still high, but the patient didn't have like a hemorrhage or a stroke or anything like that. So this still needs to be monitored and controlled, and these patients are given medications and they are controlled for 24 to 48 hours. Low blood pressure, hypotension. So our last two slides focus on hypotension. And so as we can see, it's not as of a hot topic as hypertension, but it is something that definitely needs to be discussed. So the term for hypotension also incorporates what we call orthostatic or postural hypotension, which means that these patients will have a decrease in blood pressure through movement. Okay, and the decrease usually happens in the systolic, where it will drop or decrease 20 or to 10, less than 20 or less than, excuse me, greater than 10 or 20 millimeters of mercury within 3 minutes of moving. Okay, and they say to a upright position, but it could be whatever position. Okay, now why is this important to know? Well, if a person has a fluctuation that much just from moving around within 3 minutes, that can cause them to have the drop in blood pressure causing them to have like a faint feeling, dizziness. They'll be symptomatic from this. And these patients, I will tell you, especially your geriatric patients that are like this, can be a very high fall risk. So excessive increase in heart rate by 20 to 30 beats per minute may also be diagnostic, because when the body recognizes that the blood pressure is dropping, it will increase the heart rate. The heart will actually pump faster to try to push more blood out to help the pressure situation. So a couple of things can actually be a risk factor for this. It may be a result of a problem with the vasomotor or baroreceptor response, which is what we went over with the short-term regulation. It could definitely be an adverse reaction to drug therapy. So if you have patients that are on hypertensive meds, and let's say that medication is not controlling it, properly, it can lower the blood pressure a little too much. Sometimes patients also have something called arterial stiffness, where the arteries are not variable or moving in a sense where they should be. These patients can also have volume depletion, and where the volume of blood is not there. So that can be anything from a person having like excessive hemorrhaging to definitely something like a hemorrhagic shock, where the patient's just bleeding out and, going into a state of shock, and the blood pressure does lower, definitely gets lower in that type of situation. And it can also be secondary to certain diseases. So the treatment here, you want to definitely review the medication history, because some medications are known to drop the blood pressure, especially if the hypertensive medications are not controlled, if it is that type. You also want to teach your patients to move slowly during positional changes, because that can help. They should also avoid hot environments, large carb heavy meals, and when the symptoms begin, um, squatting, bending forward, or crossing the legs may reduce the effects. Okay, so just kind of teaching the patients different things to, work through the symptoms. And that is it. That concludes our chapter 16.